I am starting the back needling, and can you see the muscles again? Spine, multifidus is seen quite well as a white muscle there. Yes, that is the facet. सोनोग्राफी का नहीं आ रहा है. Yeah, that white thing. White. You can. It's quite clear actually. No, this one outline the multifidus. It's coming on the screen. Yeah. Okay. Is the multifidus outline. The above that is the spinalis. In fact, it's going wider. Okay. Yeah, there. Now, can I do the needling? Yeah, you always keep the sheath on, and you hold like this. By the way, it is not a good idea for you to follow what I am doing. So, because for this movement of the hand, you need a lot of skill and practice. Somebody hold this for me. Somebody hold it. See what दूसरी needle दे. See what you should do is this. Hold this like this and then do it. Okay, this is a better way of doing it. What I did just now was I do this. I am holding with these two fingers and doing this. This you will not be very comfortable with it, and when you do it, try to do it like that, you will be hurting the patient because your hands don't have that practice. So it's better that you put the needles and then put the probe. Okay, now I am introducing the needles. You can see, yeah. Can you see my needle coming in? You can see the jiggle of the needle, but there you can see the needle. You can see the tip of the needle in multifidus just above the. Can you see? Come there, down below. See, I am in the multifidus. Okay. And this is another needle which is coming. I am hitting the bone here. And then this is all, both these were out of plane. This will come in plane. Somebody was asking yesterday whether you can see the needles or not. You can see them. Can you see? This takes a little bit of hand-eye practice. That has to be developed. There is no two ways about it. You have to develop it. Yeah, all this work is going on in spinalis. See, this is the spinalis. Can you see? The spine you can see now. This at this corner. Yeah. Now you can see the multifidus also pretty well. I will try to come into the multifidus in plane. Let's see. See, I am in a shallow angle here. So I will try to come. Now this I am not going into the multifidus. Instead I am going into the depths of spinalis only. Can you see? Spinalis. Atmaram dukta? Thoda sa. So I asked him that question so that you people can understand that it is not particularly painful. But however, if the patient is very nervous, let us say, then it will become painful. So here I am putting it from the other side of the probe. See, I am in the spinalis now. Here I am entering the multifidus. Let's see. See, can you see the needle tip now? It's entering the multifidus. Somebody wanted me to show multifidus. I've shown you. Okay. Okay. What I'll do is I'll do this with my left hand so that it is better. Okay, this will go very well into the multifidus. All these, yeah, I am out of plane here. See, can you see I am in the lateral part of the spinalis? If I want to go into multifidus, I have to direct my needle like this. Can you see? I am coming near the, I am right, I am about to enter the facet, which again I don't want to do. So I am coming into the multifidus here. I am coming into the lateral aspect of multifidus. Now I am going into the, can you see? I am entering the multifidus, entered completely. Yeah. I'll put some more needles here. On the other side, see, this is the spine here. By tradition, this has to go laterally. So I am taking it like this. Okay. Now you can see the spine there. Okay, both sides multifidus. All right. This is the multifidus of this side. Entering the multifidus, you are able to see or no? Not see. Yeah. You can't freeze to show a dynamic event. Huh? The muscles, okay. Let's see. Identify. Those thoda depth देना. Yeah. Okay. Can you see the two laminae? Just above the laminae. Now the multifidus is looking blackish. Okay. And on that is multifidus. And that is spinalis. Okay. Here I am sliding it out to show you the facet there. Her arrow is right over the facet. Medial to the facet, between the facet and the spine is your multifidus and the spinalis, both. Give me another needle. So I'll show you here. Can you see the needle coming in or no? That's entering the multifidus. Okay. You can see all the needles are only so much inside. He's a skinny fellow. He got pain. That was an LTR there. So he's not very tender. That's why you are not seeing LTRs. Now here again, here somewhere I'll go in plane here so that you can see 50 there, Talata. I'm entering the multifidus. Can you see? No, I'll show you the needle. Can you see? See, this is my needle entering from the spinalis into the multifidus. Okay. That I cannot tell you because even if I tell you, you will not understand what I am getting. That's a sensation built into my hand, not into your hand. See, usually what we do is one needle at each level. Today for your demonstration, I'm putting in more needles. He's got backache, so he will benefit from it any which way. Now, here is your spine. Can you see the whole spinous process there? And you're seeing quite a lot of the, I will do a shallow needling. You have to understand one thing. If the needle goes parallel to the probe, you will see the full needle nicely. Otherwise, there are many parts of the needle which will not come in the thin beam of the ultrasound. So you will not see that very well. Now, can you see? I'm going, but if I have to angle it there. Can you see the whole needle? You have to go inside. This is just above the multifidus. Can you see there? So go in some more. You saw the needle bending when I do this because I have reached bone. I am jiggling the multifidus. It is a little tighter than usual. Okay. So the actual need. Oh, Lata, माझं पायावर पडला. No, her, she put it, fell on her hand. हे थोडं काढायचं लता. काढ ना प्लीज. मला बिटडीनचं हे पाहिजे. हे घेऊन टाक. ओके. Okay. Now, if you people want to see 75 day, this is the longissimus. No, this is actually iliocostalis. Can you see the iliocostalis outline there? Please point out. Okay. I will enter into the iliocostalis. Can you see? Maybe we'll get a LTR. If I go fast, I may. There was an LTR. There was another LTR there. There again, he got an LTR. See, wherever we elicit an LTR, he will get pain. Okay. So now I am going at a deeper plane. Depth increase karo. Now here is your QL. So I am coming in the deeper plane. Can you see my movements in the QL? I will try to come parallel to the needle. I am not in the QL now. I am in the above. So I need to change my angle. Can you see the needle now? Yeah, it's going. Can you see? Into the area just beneath the transverse process. I'll have to show you a little better. You saw the needle for a second there, I think. Yeah, there you can see the whole length of the needle. Yeah. QL again we can take. Again here you can see the QL extremely well. 50 day, 40 day. You can see the peritoneum moving beneath that bright white thing, and here is my needle coming very superficially. It will not it will enter only the medial end of QL. Can you see? I'm entering the QL. I'm jiggling the QL there. I have entered the QL. Somewhere I'll have to show you this needle. Can you see the jiggle of the needle, but not the needle itself? You can see the outline of the needle now. I'm in the, this is probably entering the psoas. So let me see if I can show you the psoas like that. Betadine. Yes, please. Can you enter it more vertically? Oh yes, of course. It will be out of plane. Yeah, you can. Out of plane will be very easy actually. It's the easiest thing to do, out of plane. I'll show you. Just near the longissimus, right? See here is your spine, spinalis. Spine, show her the spine. Yeah, that is the spine. Next to that is spinalis. Nice big gola there. This is okay. Next, come here, longissimus, and then you come here, iliocostalis. Beneath these is the QL. Okay. I will come here. and show you the QL. What she is showing you is the strip of QL there. So I am entering now in the QL. In the sense, I am now coming through longissimus. Can you see my needle? That was an LTR. And then, can you see I am about to enter QL? I have entered QL. 50 delata. 40 is not sufficient. 4 centimeter is just in the top. Peritoneum you are not seeing. Yeah, just now you are seeing. Thoda increase kar depth. Yeah, can you see the peritoneum there? What's moving? Right at the bottom. So we are very safe. We are in the QL. We are in fact not even fully in the QL. My needle is coming now. Can you see this? It is in the longissimus. Now, see, I am not yet in the QL. In the QL now. Yeah? Okay. Psoas is something I have to show you. Maybe I should show you on the other side because there are too many needles here on this side. Yeah. Can we take the other probe? Let's get the other probe because that will show me better. Huh? Huh. Any point of the muscle. See, my principle is I am looking at the problem in the whole muscle. So I am not constrained to go to a point of pain, which is the MTRP. As you saw just now, I keep eliciting LTRs here and there. So to me, the target is the whole muscle. And many times, where you think the muscle is very calm, suddenly you will see an LTR. So I believe that we cannot really look for MTRPs and do needling of them. It's like looking for a needle in a haystack. Several needles in a haystack, you can say. We are waiting for the other probe to come.
Can we take a question, ma'am?
It would have been better if one of their machines had come with the other probe. Why don't you get? There are two machines. Ah, acha, acha. Okay, okay. Oh, then what is the use of their machine if it cannot be connected? Why should they give it for workshop? If we had organized the workshop and if we didn't have our own probe, I mean our own machine, we would not be able to do the workshop then. They should bring a machine which has everything, right? Okay, now I am looking with the deeper probe. Okay, can you see the trident sign there? Very well. Depth come karo, then you will see the muscles, individual muscles quite well. So once again, let me refresh your anatomy. These are the spines. Sorry, on top. This doesn't have the kind of resolution that the high frequency probe has. Okay. Anyway, spine is too superficial to be picked up by this, but you can see the laminae. Okay. In this view, multifidus is the lower one. Depth kam karo or kam karo minimum. So can you show just come down, 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 down. That is the multifidus. Okay. That's a line there you can see. Little higher, little higher. Yeah, that is the multifidus. The one on top of it is the spinalis. And here all these are the laminae. And then as I come down, if you see the laminae, they are at about 2 centimeters. Show them the marking. First centimeter, second centimeter. And then as I come more laterally, you will see, can you see these are deeper transverse processes. Between the transverse processes is your psoas. थोड़ा depth increase करो. Now, can you see the trident sign and the psoas there? Just on top of the, probably the upper 1/3 of the transverse process will be the quadratus lumborum. So I can do the psoas here also, in a out of plane. See, I'm coming from medial side. I don't know whether it can be seen. The probe is here and the needle is coming here. And you can see in the ultrasound now. Can you see? I'm coming. Can you see? I'm entering the quadratus. And then I'm entering the psoas. I don't think you can see the psoas, needle in the psoas. Are you able to see? No. You're seeing it, see, you are seeing the jiggle more in the quadratus lumborum rather than, or I will, okay. Huh. Huh. I hope you people can see me. I'm touching my head. I'm touching my head to hope that no needle breaks in anybody. Having said that, we were looking at our numbers, and I understand that we have done something like how many? 1,20,000 needle sessions. So in 1,20,000 needle sessions, I have not had any needle breaking. So obviously these needles are pretty tensile strength is very good. Okay. Now I'll try to see if I can show you psoas needling obliquely, because that way you can appreciate the needle. Yeah. Can you see the transverse processes? The trident sign? 3 transverse processes, the psoas and the quadratus lumborum. Okay. Let me see if I can go like this. Show again. That's the QL and the psoas. Can you see my jiggle in the psoas? Probably that is the transverses. Transverses. I hit the nerve root. Yeah. I was just touching it. I was not hitting the nerve root, nor was I going through it. As I told you, at that depth you have to go slow. So thoda increase karo depth. Okay, give me another needle. Let me see if I can show you here. So it's quite easy to go into the nerve root also. Okay. Can you see my needle? I'm going straight for the transverse process. Can you see? So I need to go a little more in this direction. Now this is pain. Duktare ke shock watla. Dukla na. So we are doing him some good. In the sense he's got pain and we are eliciting pain means his pain will come down. I'm still in the quadratus. You can see the quadratus shivering almost. So he's got pain there on this side. We didn't get that reaction on this side, on the left side, whereas he got this reaction on the other side. So let me see if he's got the same. Let me see if I can do a similar demo in plane. See, to do a needling of the psoas in plane, I would have to come. Can you see the lamina there? Show the lamina, please. That is the lamina. You can see the facet also open. There are 2 points. Come down. Can you see the epidural space? Can you see the movements there inside? Come down. Yeah, that is the pulsating epidural space. I'm in the intervertebral area. Okay. Transverse process will be below this. Below the lamina, there is a step you can see. That is probably the transverse process. Beneath that will be the, you can see this thing moving, peritoneum moving. Thoda increase karo depth. Yeah. एक 75 चा needle देना. Okay. ठीक है बघू. हास पुरते का बघू. Yeah. I'm coming in line. Can you will see my needle in plane. See, I'm doing from the reverse direction, so I need to align my probe properly. I'm not able to visualize the needle, so let me go. It's easier for me to do on this side, but this area is full of needles now. Let's see the jiggle. No, I'm very superficial. If you see, I'm in the spinalis almost. So I need to come more. Dukla. So this side is very painful to him. See, most of the time, I told you that we usually do with Prilox. तुला Prilox केलं नाही ना रे आज? Okay. खूप दुखतं? Sorry. हा साईडलाच दुखतं तुला? See, let me go with the other probe. That will be easier to show, because a high frequency probe is always very much clearer. Our only problem is after 4 centimeters, the high frequency probe, the clarity goes off. Whereas this probe, the clarity is always compromised, but you can see depths. In a fellow like this should also be good. But the advantage of this probe is that it gets a large area, surface area into its plane, whereas this gets only so much. High frequency for superficial work. For deep work, if I want to show psoas, if I want to show quadratus, next patient is heavy. So in her, it is not going to be easy for us to see everything with this. Let me see if I can show you the same things. Can you see how much clearer this is? This is the high frequency probe. Depth increase karo abhi. Depth increase karo or till you see the peritoneum. Can you see at the depths how the clarity goes off? Spine. Please point out the spine. Spine. Spinalis. गेन कर सकते हैं. थोड़ा फार गेन बढ़ा दो. दे नीडल. Can you see my needle? It's at the quadratus. I'm hitting the transverse process. See, this much of the depth, it is at the transverse process. If I want to enter the psoas, I would have to go a little like this or here. I have to go in between the two transverse processes. So 75 de lata. 75 because pochsat nahi. दुखतं रे? दुखलं नाही? So all things have relaxed in him. I want to see the needle first before I proceed further. Not seen very well. I think I'll do on this side, because that side I'm going like this to do, which is not a mechanically, no, ergonomically it's okay, but mechanically it's not a good thing. See, when you are standing and working like this and your machine is in front of you, you're perfect ergonomically. I won't get any neck pain, I won't get any hand pain and all that. Whereas if I put a machine here and look like this and do, finished. My neck will go for a toss, my back will go for a toss. And it's not just me, anybody who does it. Here. Where is the QL? Let us. See, there are too many needles and I have to find place for the probe somewhere and put it. Okay? Here is your spine. Here is your probably transverse process. This, the white one, not sure. Let me see if it is the transverse process. Ek 40 de? That's what I'm saying. Ek 40 naiter 50 च दे. 40 50 च दे. I'm trying to see what this is. It might be the bone. That is the transverse process. Can you see? I'm going towards the white line. Yeah, it is the transverse process. This is the transverse process. So the black muscle coming from that area is the quadratus. Beneath that will be the 75. Yeah, that's it. You're right. So I will need to go beneath that bone. That is the underside of quadratus. Okay, let's see if I can give you the full view. Can you see my muscle? My needle is coming. Can you see? Yeah, I am going straight for the bone. So I am hitting the bone. Can you see? I am hitting the bone. Transverse process. The tip of the transverse process. So now I have to see he got an LTR there. So now I am going in a slightly deeper trajectory. I have to come out fully if I want to change the trajectory. All these movements are not painful to them. Only when they get an LTR they get pain. See, can you see? I am coming in a different trajectory. I am going through the QL. Can you see? I am entering the psoas here. That is, unfortunately, it's in the shadow of the transverse process, so you don't see it. I am going here. Let me see if I can go there and show you. See, that's what I'm trying to see. See, there are other needles on top. Can you see that needle? That's another needle. It is not this needle. The needle which I'm trying to do is here. It's just sliding under the transverse process. So it may not be seen. Since it is just under it, it's in the shadow of that. So whereas, see, I'll get the transverse process out of the view. Here will be your psoas. See, in this area. That area will also be the area for the nerve root. So in that area between her arrow and this edge, I would have to go very slowly because I can hit the nerve root. So let me see if I can show you this. Since we are dealing with very thin needles, it takes, Sorry, Lata. See, I have to align my needle to the probe if I wish to see it. I've got the view there, but my needle also has to align itself. You can see my needle now coming, entering the quadratus, almost exiting the quadratus now. Can you see? And going into the psoas. This is the area of psoas. So here I have to go very slowly because that's his nerve root area. See, the whole 75 has gone in a thin, lean fellow like this, but it has gone into the psoas. Okay, I think this is enough in him. Shall we take the other patient? Okay. So, are there any questions so far? Atmaram, thumb. I'll show you also, since he is thin, lean, it is better that I show you his gemelli if possible and their needling. Thoda khali hai. Oh, sorry, I'm so sorry. I thought. तू हलू नको रे. हाँ ओके ठीक है. See here once again, you people want to see this, I'll show you. Sacrum, sacroiliac joint. Can you see? Depth come kar do, then you can show better, lots better. End of sacrum, that is the ilium. If you want to really confirm whether it is the ilium, simply move up till you see the PSIS. That is the ilium. Okay, that is the ilium. So your SI is here. Oh, that might be the sacral foramen. Yeah. Somebody wanted me to show the sacral foramen yesterday. Today it's coming and saying good morning. Yeah, this is the sacral foramen. And go to the SI joint. And as I go up, the ilium is coming up there. This ilium. Okay. So, and in the middle, I am seeing one after another spines, and here the sacral hiatus. Okay. For those people who wished, oh तुला इथे दुखतं ना रे? अच्छा अच्छा. No, he had some abscess or something. See, here is your, say, caudal epidural space. Okay, and here comes, if you wish to see the, sorry, see, this is sacroiliac, sorry, yeah, sacrococcygeal area. See this. Nice ligament you can see. And then if you want to go down, you will see the coccyx. Can you see the first segment of the coccyx there? Can you see? Sometimes for doing ganglion impar, you can simply go to the side where it has disappeared. See, the bone has disappeared now. Here there is the bone. Just move a little this way. The bone is gone and you can go in like this and do the ganglion impar. Okay. Now coming to the muscle, let's come back to the muscle. Here is your, are you okay? Your leg? It fell, no? Okay. Okay. Here is your gluteus, okay, maximus, and the piriformis. You can see the second muscle, that's the piriformis. If you notice, I am away from, usually you find at this level piriformis, and if you go here, it is still the sacrum. Can you see? Sacrum to piriformis. Okay, and now this is a rough guide. at the end of the sacral hiatus. Here is your sacral hiatus. Okay, so at this level, this is piriformis, and here you are likely to see the gemellaic. Can you see that small little muscle? 3 muscles you can see very well. 1, 2, and 3. Okay, you want to do, I'll do needling of this just to show you. Immediately the gemelli. No, piriformis is above. Now you won't see. See, you have to understand there is piriformis here. In this direction it's coming. Beneath that are these 3 muscles coming. See. Can you? So my needle is getting lost in the gluteus. It's not coming down. So come down. I have to change the trajectory. See, what happens is when you're putting the needle changes direction a little and it will not be seen. This is a thin little needle, no? I'm still lost in the gluteus. So, usse acha hai, I will come directly down. 50 there, Lata. I'll try to see, of course, till whether it goes in line. See, it's coming deeper. I can come even deeper. That was an LTR. Can you see it's entering the gemelli? 50 there. See, entering gluteus हो गया almost. Yeah, shock सारखं काय वाटतं का रे? नाही ना? आता? नाही. That is, the needle has entered all three. Now, please watch this probe. Are you able to see this? I don't know. In the clinical picture? Yeah, you can see this very well. Now, I think it is better that I show you with my hand like this. Okay? Now, as I move up, you will see the 3 muscle picture going, and you will see the piriformis. Can you see the piriformis emerging here? The black piriformis. Yeah? So it's a strip of a muscle basically. So you need to do this. When you do piriformis, you should also do it. And the guide to you is the sacral hiatus, just below the sacral hiatus. So, huh?
To do this gemella and all, isn't this out of plane approach better?
Out of plane is better.
Because here there are no very sensitive structures that you like
Yes.
to do that.
No, sciatic is there still.
You don't need to keep that hectic.
Sciatic is there. Big fat sciatic is there. No, but what I'm saying is out of plane is much easier, and that's what I do also. But let us say I'm doing something like this in a patient where I want to register or I want to report or I want to teach you people where all my needle is going. Then I have to come in plane to show this the course of the needle. For doing it, I don't need to go in plane. Because this is not a very, the course of the needle is not in a dangerous area. But let us say if I'm doing a needling here, of course I will not put the needle, he has no pain here, so I cannot put the needle. See, when I come to the intercostal space, depth come karo. Depth come karo. See, can you see the pleura moving and the intercostal? So here I definitely want to see. Oh, you can see very well. You can see very well. That is the beauty of ultrasound. You cannot make mistakes unless you do not know what you are looking at. The problems will come because you are not good at it. But once you become familiar, you study all these things, it becomes very simple. See now, see in some cancer patients, I have done needling right around the pericardium because a mastectomy lady, she was getting a lot of pain in the intercostal muscles. She had many mets in all those areas. And you can give her morphine, but it will not give her relief. So for her, I used to do the needles, and she used to say, "आप needle ही करो मुझे, मेरा दर्द चला जाएगा," and it would go. Then once I did Botox, I didn't have to do needles anymore in her, which was good. See, can you see this now? This is my this is the rib. On top, can you see this bright line is the rib? And here I'm sliding down, and you can see the pleura, moving pleura, unmoving rib. Can you see? Moving pleura. It's practically impossible to miss the pleura. And if I were to do a needling here, I would want to see the whole needle. And even here I can come out of plane, but I want to see the tip of my needle all the time. I cannot depend on the jiggle of the needle to know where I am. Very important, because otherwise I know of a situation where somebody decided to do PEC 1 and 2 block somewhere. Under ultrasound they did. But obviously they were not familiar enough with the local anatomy. And under ultrasound they produced the local, pneumothorax. So unless you familiarize yourself, you can goof up. And familiarization cannot be on a patient. You have to take a volunteer, study. Volunteer, study. Then, of course, you go to a patient and do what you want. Whether you want to do a block, whether you want to do a whatever it is that you want to do. 50 de ek. I'll also show you the medius, and then after that we'll move to the other patient and do the depth increase. See, for the medius, first and foremost, you have to see the bone. Depth. Even in the skinny fellow, you can see that I have to go to 4 centimeters to see the ilium. The first muscle there is gluteus minimus. That's medius. This is minimus. Come down. That is minimus. Go up. That is medius. Okay. Gluteus medius is the main abductor of the hip. Minimus is also an abductor of the hip. And where the gluteus ends, the vastus lateralis starts. So the lateral thigh pains you have to go and do the gluteus medius. Okay, bas. I think Atmaram, tumchi sampla atami karte. Okay. Yeah, we can take a question while we do the card. Okay. Yes, please. Yeah, he's been a very good sport.
Are there any specific contraindications for dry needling?
Local sepsis, and if they are on blood thinners also, it's not a contraindication. We are using very thin needles, but please make sure that you are not going through any vessel. That's all. If they have bleeding disorders, and if they have local sepsis, absolute no. I've had some complications which were unexpected in dry needling. There was one patient who was allergic to prilocaine, Prilox gel. So she got a lot of rashes after going home. So it was a very big problem. And then there was another lady dentist, who had severe allergy to diclofenac cream. She went home and put diclofenac cream, of all things, and she went into a near anaphylaxis with a cream. And she was related to a senior doctor. So she was in Goregaon, and she said, "Ma'am, I'm getting a rash and I'm getting very scared." So I didn't know what to do because she's so far away. What do I tell her? So I told her husband, please take her to the nearest hospital and tell them that she's got an allergy. Because even in a hospital, in a nursing home, you do not know who's the doctor there. Many times you will have all kinds of doctors as, houseman, RMO, whatever. But fortunately, they had a good doctor there and said, if anything, let them give her adrenaline, this thing, nebulization. Because I'm more worried about her throat. But she was talking well, so I was not very, very worried because she's not going in for laryngeal issues. But she definitely had rashes all over her face. And then I told the senior doctor, her uncle. Then he said, no, ma'am, don't worry. I know the hospital nearby and they will take care. And he spoke to them and all that. So, and then other complications of dry needling, bruises are very common. Ugly looking bruises. Those bruises, if you look at them, people will think we have done something horrible to these patients. But the patients themselves are least bothered about it. Because they say, my pain is gone. What does it matter if this bruise is there? It will go in a week. So they are, some of them do have ugly looking bruises. And then what other complications I have seen? Not really. Not really anything. One patient was very peculiar. I was doing her chest wall. I've done it under ultrasound. तुला सांग हळू रे कुठे तू तू हां जा पळून कुठे जातो तू lot of pain in the chest wall muscles. I had to do her serratus anterior and such muscles. If you want to see serratus anterior, I'll show you. Atmaram, 1 minute. It's a झोपू नकोस ओके झोप असं नाही रे सरळ झोप. So I had done serratus anterior and pec major, pec minor, and all those. Basically, wholly chest wall. I've done it under vision, so I knew that I have not touched her pleura anywhere. But her complaint was after the needles were removed, she says, my chest is very tight. That is her complaint. Chest is very tight, chest is very tight. So I said, okay. I took an X-ray here, it didn't show any problem. Air entry, normal. But this lady was very hyper educated, very sort of nervous lady. So she kept saying, I have a tight chest, and all that. And then I sent her for an X-ray. That showed normal. Then I told her, this is a reactionary spasm to the needling. Sometimes, even after the needling, for relaxation to happen, it takes time. Most people relax immediately, but there are some who don't relax immediately. Now here, can you depth come kara, depth come karo, depth, come. Can you see the pleura? And can you see the intercostal muscle? On top of it is that muscle is your serratus anterior. Okay, that can be needled. The most easiest things are the abdominals. They are the easiest muscles to needle, and which you have to needle for abdominal pains, visceral pains, post-surgical pains after cholecystectomy, hernia and all that. See this. Oh yes, these people get pains. Depth increase kar. Can you see the 3 muscles there? Depth come karo. Depth come karo. Aur come karo. See all this, the external oblique, internal oblique and transversus. Okay, and as you go here, of course, is our dear rectus abdominis. Yeah, okay. Huh?